Hello, I'm Peter Lackman. I'm the Clinical Director nationally for the SAFE project. And today we're going to talk about some principles about SAFE, as well as the quality improvement and patient safety background to the project. The first talk we're going to do today is about translating quality improvement into action and how you can do this. I've taken 8 practical steps that you need to do in order to achieve quality improvements in any project, but particularly in SAFE. Now, the key ingredients to quality improvement are starting with something called respect. That is respecting what people are doing, given that they work very hard every day to deliver care to patients. So once you start with respect, people will start respecting your attempts to improve care. And in SAFE, this is one of the key ingredients that we start with. The second one is to really contextualize what's happening. We have tried SAFE in over 50 places across the country, as well as in other countries. And in each setting, the context is different. Different people, different patients, different processes. So you really have to try hard to place the SAFE intervention within that context. You do this while not compromising the underlying principles of safety and quality improvement. That's essential, because if you do compromise the principles, then you're not going to have the right outcomes. So safety and quality are contextualized, but the overall principles of safety and quality are not challenged. It's very important that the next step is taken into account, that is sustainability. I have seen many quality improvement projects fail because what they've done is not considered what's going to happen when the project is over. And then what happens is one reverts to the mean, i.e. where you were beforehand. Often people say it's good that the project's over, now we can carry on working as we used to. It's always easier that way. So build sustainability right in from the beginning and say what's going to happen after we stop the project. And that really means it becomes the way you do business. And in order to do that, one has to make it relevant to all participants. Everyone who takes part in the project has to see some relative advantage over the old way, i.e. the new way makes it easier to do the work they want to do. In our case, it makes it easier and safer for the patients. So here are the 8 steps. Over the next few minutes, I'll go through each of these steps to explain them to you. The first is about person-centered care. The second is about context, as I've already alluded to, the importance of having context as central to everything that you do. The third is about understanding your resources and building a team for quality and safety. And this is where you can be very adventurous to ask who's in the team and who should be in the team. We then develop a program based on context and the team to meet the needs of everyone in the project, from patients to clinical caregivers to those who support the clinical caregivers, i.e. everyone must see that the program meets their needs to deliver care to children. The third is to develop the improvement paradigm. That is, you need to have a theory and a method of change. And we're going to teach you the theories of Deming and the methods based on those theories that help you implement change. Change never happens without leadership, and you really have to build in leadership from the start. If you do not consider who the leaders are, and I'm not talking about the official leaders, but I'm talking about leadership at every level of the organization and of your clinical team. If you do not consider leadership, then you're not going to have change. I mentioned sustainability. One often forgets it. So sustainability is about how this continues on forever and how you continually improve, because that is what sustainability is about. And finally, it's how you share the learning. And this is what this series of lectures is all about. We at the college have had great success over the last 4 years in the SAFE project. We have seen teams change, and now we are sharing the learning, and on this course, you're going to learn how to share the learning with your team, with other teams, as we spread SAFE across the country, and in fact in other countries too. Section 1 is going to be about person-centered care. Now, often you've heard about patient-centered care. We call this person-centered care because it's more than just the patient. It's about patients and providers. And we really believe in listening to stories to bring reality to the work that we do. Now, patients have told us what they want is coordinated, safe care. They want care that enables them, care that provides for their ability to make choices, care that is around their needs, yet is standardized to the highest principles of safety, quality, and the theories we all base our life on, that they don't depend on who's on and who's not on. They get the care they need at the right place at the right time. I'll be talking more about this in the safety section. However, when I talk to providers, as healthcare providers, doctors and nurses, what they also want is standardized care. They want to be able to deliver care in a way that they should, and they want to make sure they get the best outcome for their patients. So listening to the stories of providers as well as stories of the patients is essential for us to understand how to deliver person-centered care. Now, if you've read the books of Atul Gawande, you'll find out that that is essential to all that he writes about. In this excellent book called Being Mortal, he talks about stories being the essence of life. We live by stories. In fact, when a patient comes to you, and a parent with their child, they start telling you a story. We call it the history. The history. When you go to the next step and you're discussing the history, you are telling the story of your experience with the patient, with the child. The history becomes real, and it is a story. Medicine's all about stories. We make diagnoses based on stories. We are telling stories all the time. What we're not good is telling stories about our own experience, what it was like, when it was difficult, our successes. We are going to introduce the huddle to you. And the huddle is a way of telling stories in a structured way so that we can determine what is best for our patients and how to prevent deterioration. I'm telling you a story now. I'm telling you stories about what happened in our lives on the SAFE journey. You are seeing the result of many stories that we've spoken about. Let me tell you a story about the first time that I had a serious event, not that I was involved in, but one that involved a fellow colleague about a child who inadvertently got a wrong dose of medication. In this case, the child got potassium chloride instead of sodium chloride. And as you know, that's fatal. Now, when we look at it in retrospect, it was a human error factor based on human factors. The two vials were kept side by side, easier to mix. The process broke down. The infant got the wrong dose of the wrong medication and died. Now, that story was never discussed when I trained. It happened when I was a registrar. I happened to be the registrar on that night. But that story was never discussed in the team. Now, had we discussed the story, we would have discovered the human factors error. We would have looked at ways we could improve. And often we do not tell stories about what goes wrong. Moreover, we often don't tell stories about what goes right. And what we're going to do in the huddle is learn how to tell stories in a structured way so that we can improve care. Now, safety and quality must be viewed from the eyes of the patient, not only from our eyes. And the reason I point this out is that often we talk about adverse events. From the patient's side, they talk about harm. What happened to them? We don't classify harm often as adverse events. So for example, a child who's going to the operating room and the operation is cancelled. The harms there are starvation and psychological harm, but it's not an adverse event. Can you see the difference? So we need to listen to the patient's stories. And when we do the huddle, a lot of it about is what the patient and the parent tell us so that we can take that into account in order to have safer care. And the mantra that we have now is this question, not what is the matter or what's wrong with you, but what matters to you. And if you think about that, We've got to get synergy between what matters to patients and parents and what matters to caregivers. And that's why being person-centered is very important. The next step is understanding context. Now, this is rather a simple concept. Understanding where you're going to do the improvement, and in our case, where you're going to introduce the huddle. Now, context is something that is really new in the improvement field, because often we understood, why does something work in one setting and not in the other? And that's because clinical settings are very different. When we started the huddle project, we had 6 children's hospitals from across the country and 6 district general hospitals, some of them larger academic centers, but have a district general children's wards, and others more isolated, say, outside of the big centers, the only hospital in the town. All had different clinical settings, all had different challenges, and all had different ways of implementing the huddle. So first step is understand your clinical setting. The next thing about context is understanding who are the key people, who are the decision makers, who are the people who will impede progress, and who are the people who will make sure it happens. And I'm not talking about the clinical leaders at all levels, I'm talking about everyone. So that's from the housekeeper and porters, the parents, the play leaders, the school teachers, the doctors, the nurses, the allied professionals. Anyone who works in your area may be important for the huddle. And when you hear from the Royal Free Hospital, you'll see that there, the school teacher is part of the huddle. And it's very important that you take into account all the people that will know something about the child. The next one is to understand your patients. Who are the patients in our huddle, in our area? Who are the patients we're caring for? And who are the ones that we really need to apply this to? And how do we involve them? And how do we get their views at all time? We have to understand what the problems are. What are the challenges? What are the harms we have in our clinical area? What are the things that impede progress? How are we going to apply the huddle in our area? What is the best time of the day? When do we do it? How do we do it? These are all different in different places. There's no one recipe. However, just like gravity, the apples fall to the ground wherever you are, so the safety principles apply wherever you are. You don't change the principles, you just may change the application of the principles. And you have to ask, why are people here? What is the reason they come to work? And I know that most doctors and nurses, if not all, come to work to do a good day's job to keep their patients safe. The problem is we often don't know how to keep our patients safe, and that's when we have harm. So we really need to look about that. And in the second talk, I'm going to talk about the principles of patient safety. And what is the motivation? What makes people get there? And understanding this, what we call intrinsic motivation, not about safety, but what drives the people who come to your ward every day to work, what makes them tick. That's very important in understanding the context, because every context is totally different, but the principles will remain the same. Well, if you understand context, we now have to understand the people, the resources we have, because they make up the context. Now, in the NHS and in other settings around the world, there are not enough resources. However, there are much more resources here than in many other places. It's how we utilize resources, how we do not waste our resources. That's the human resources as well as our physical resources. So the aim of this program is to help us make a better team and change the way we utilize the resources. And team building is essential part of quality improvement and a vital part of patient safety. So you need to know what are your resources available to change. When's the best time to implement change? If you're going to change the way your house staff are going to work, the young doctors and the nurses, then it's best to do it when they're starting, not halfway in. Then new doctors need to come in knowing the new way of working. So I think that's a good time to test it out before they come and then to implement and say, this is the way we do things. So for example, if you're implementing a new way of handover using either SBAR or iPass, then what you should do is test it out so that when you have a new set of staff coming on, you can say, this is the way we hand over here. And we do it consistently, and this is the way we do it every day. You need to look at the wealth of innovation going on. Many teams are doing many other things, and this is just one more thing you're asking them to do. You need to understand who are the innovators, who are the people who will start change, the early adopters, the ones who will take it forward. You need to look at your team and analyze them and see how's the best way to get them to change. You do this by building a community spirit, by making fun to change. We often call that breaking bread. We need to spend time together discussing how this works and make the introduction of patient safety not something onerous above my work, but something that's part of my work and that makes my work more profitable in terms of self-belief and understanding, and make me really want to do it more because I get more satisfaction. And I think that when you see how it's changed many of the clinical teams, then you'll understand that the introduction of the huddle can be a game changer for the way your team works. Inclusivity is essential. No one should be excluded from patient safety efforts or from quality improvement programs. Ask everyone if they want to join, and even those who say they don't want to join because they have no time, try to find time for them. For finding time is an essential part of quality improvement. And this means we have to think about the system. And the system comes from the theories of Deming. Deming was a statistician who went to Japan soon after the Second World War, and he worked with Toyota. And if you've learned about Lean, Six Sigma, TQM, all different quality improvement measures, those come from Deming. Now, Deming had a theory called profound knowledge. I've tried to make it more simple. The reason why he called it profound knowledge is because with profound knowledge, it means you never really understand it. It's just so profound. And I found that true, so I've tried to make it a little simple into 4 things that he said. The first thing about your system is you have to understand the system in which you work. That's your context I was talking about. How do you do things? How do you do business here? And I'm going to talk about it in greater detail about the microsystem. In order to do improvement, you're going to study the variation in the system. Why does it work on one day and not on another day? What's the difference between the system on weekends to weekdays, mornings to evenings? Why is it different at night? What's the variation? Why do some people do things differently? And actually, variation is quite difficult to understand, but you have to measure the variation and study the system. And that means studying the process in the system. The third thing that you have to do from Deming, what he called psychology, is understanding the people in the system, because people cause variation. It's the people who do things differently. And what you really want to do is only have variation where needed, not inappropriate variation, which is created because people like doing it in a different way each time. Variation needs to be dictated by the needs of the patient, not the needs of the provider. And finally, you have to have a theory and method of change. These 4 principles, Deming called the lenses of improvement. It's how you look through these lenses is going to tell you how you're going to improve. So now if we look at the system we're going to do, a clinical area, we're going to look at the people in the area, that's the psychology. We're going to understand the variation that they create by studying the system, and then we're going to have a theory and method of change. In our case, the theories will be patient safety theory, and the method will be the huddle. Now, this slide shows the different systems that you currently live in. Most clinical teams are called a microsystem, the clinical microsystem, and we are going to ask you to study the clinical microsystem. Now, if I just look at this, here's the individual with clinical skills and self-management. You have a responsibility. There you are. And surrounding you is the clinical microsystem. That is the team on your ward. And these are the people who are going to be involved in the huddle. The mesosystem, that is the other wider system. So, for example, When I worked at Great Ormond Street Hospital, there'd be a lot of clinical teams, but they were in a division. And the division is the mesosystem. And that division is in a macrosystem, which is the whole hospital. The whole hospital. Now, we are right now in northwest London, and that's a region, and that would be the network of the region. And that's all within the whole NHS. So you can see that the microsystem links to the whole NHS in many different ways. What we are asking you to do is work in your clinical microsystem. And I'm going to give you a methodology taken from the Dartmouth group in the USA on clinical microsystems. And I'm going to just teach you one basic way of analyzing your clinical microsystem as you're going on for change. Now, the Dartmouth group, that's Paul Batalden and Jean Nelson, defined clinical microsystems as a small functional frontline unit that provides care with the patient. That is where you interact with patients. And that is the building block of quality improvement, because it's the building block of healthcare. We really believe that if you work in the clinical microsystem, then what can happen? You can improve care. That's why the huddle is about a clinical microsystem coming together to discuss the children who may deteriorate, who may have delays, who may have patient safety issues. So everything we do now is about the clinical microsystem. And in order to work in the clinical microsystem, what you have to do is understand it. And the clinical microsystem comprises of a number of important elements. These are the leadership, and these may not be the official leaders, they may be the subtext leaders, the people who people listen to. It's about staff, the providers, it's about the patients, and then most importantly, it's about your performance. And that's how you measure how you do your work. And that goes back to Deming. It's how you study the variation in your work and your outcomes. And by doing that, you'll get improvement. Can you see Deming's theory here? Because in Deming's theory, he talks about the psychology of the people, that's the staff and the patients, and the performance, which is the variation and the system. So your microsystem is essential. And there are 10 elements of microsystems that you have to look at. You have to have leadership. You should have support from your organization. So if you're going to start on the huddle process, we'd assume that your organization is supportive of this change. You need to focus on the staff. What are their needs, their context? And you have to educate and train. You can't just expect this to happen. You need to really look at the interdependence of your care teams. So if you're really looking at your huddle, who are the key people there and who are the different care teams? Because there may be more than one microsystem involved. You need to look at how you perform, how you measure, how do we do things here, how do we know we are doing what we're supposed to do. You need to look at interpersonal relationships, how people work, and you need to be really person-centered. That's the patient care. You need to really say, this is all about the patient. That's why we're looking at clinical microsystems. And finally, you need to look at the community, how you look at the community and how you base this on your information systems. Often people say we need to wait for technology to come in, but pen and paper can often work well before you get to technology. Now, the clinical microsystems, as they say over here, and this comes from one of the papers from Dartmouth, it's about the relationship between the patient and the provider. And that is actually where you're going to start on your huddle. The first thing in the huddle is finding, what does the patient say? What do the patient's carers say? That's the parents in our case, or the family members. What are their views? Because that is going to be very important. And the clinical microsystem system is where decisions are made. That's where we decide what really happens. And the huddle is all about decision making, what we decide is going to happen in order to safeguard patients. So let's go on to the next step about this huddle. The huddle, which you're going to learn about later, is simply a clinical microsystem coming together a few times a day with a very specified task, finding out which patients may deteriorate, within the next 6 to 8 hours or 12 hours as it may be. This is not a ward round, it's not a handover, it's a very focused, structured discussion about the clinical microsystem, looking at the dangers and the risks that may pose their patients in the next few hours. So it's all based on microsystem theory. And microsystem theory means we have to diagnose how we work. The next step is to really develop the program to meet the needs of your particular microsystem. And that microsystem is different wherever you are. So what you have to look at is a simple fact. What works elsewhere may not work in your microsystem. And you'll see many examples that will give you of where the huddle has worked. But you may have to adapt that even more for your own microsystem. The second thing is that you have to look at solutions that your team may accept or may reject. So for example, in some places they'll say the best time for a microsystem is before the ward round, others will say after the ward round for the huddle. And your microsystem will decide which is best for you before you go forward. You have to be adaptable. That means constantly change. You have to look at ways that you can do it in your own area, and the huddle will always look different in different areas, but the principles stay the same. So being adaptable means you have to develop their own improvement and safety paradigm, not someone else's. When we started the huddle process, we had 12 teams, which rapidly grew to 28, then up to 50. And each time, we changed the way we did it, and we made it adaptable to each of the teams. Each of the 50 teams applied the principles in a slightly different way. However, they stuck to the idea that it was all about patient safety and decreasing deterioration of children, moving from reaction to anticipation. So here's the framework for quality and safety that I'm going to take you through. I've tried to make it simple. It's quite complex if you think about it. However, again, I believe in having a few steps that you can follow. Now, this is based from Duran. The first thing is you've got to plan. Things don't just happen. Duran said there were 3 major things. I've added the 4th one by building in Deming's theory into it. Many people do it this way. Plan first. So you've got to get your team together because you can't plan by yourself. So once you know who should be involved, get them together, talk about the huddle, talk about the principles, and plan what you're going to do. The next step is to build in what we call safety controls. Now, Duran, who thought about this, said you have to really measure that you're doing the right thing, that things are going right. And how do you do that? By studying your variation. How do you study your variation? By measuring. And measurement must be an integral part. And that forms a part of a microsystem, continually measuring your performance, not for someone else, but for yourselves, so that you can continually improve. And that means that patient safety and quality must be managed. It doesn't just happen. It has to have some kind of management system built into it. And the huddle allows you to do that in real time. So this is very important for you, to have this planning, this control, and this management. And of course, the last one is the quality and safety improvement. So this cycle of planning, measuring, managing, and improving goes on continually, and it's part of our daily work. It's not something extra. It said, Paul Batalden said once, that we have 2 jobs. The first job is to do our job, and the second job is to continually improve our job. And that's what the huddle is all about, continually improving to make it safer for children. So the steps for improvement based on this are these following steps. Identifying the problem, because every ward will be a different problem. So for example, if you worked at a children's hospital, more children would deteriorate and go to intensive care than if you work in a district general hospital, where children don't deteriorate as frequently because they're a different profile. You have to study the process with something called a process map and something called the 5 Ps, which is from the microsystem theory. You have to analyze the problem, see what's wrong, and we often use that with a fishbone or Ishikawa diagram. That comes from lean theory, and something called the 5 Whys, asking the question 5 times till you get to the root cause. You have to develop a SMART aim, And a SMART aim is a specific, measurable aim that's relevant and has time related to it and actionable. And that might be something that you want to do for different projects besides this one. You then have to have a theory of change. How are we going to change, and what's the theory and what's the method? And we use that as a driver diagram which summarizes your theory of change. You have to define the tasks to be done. Who's going to lead the huddle? When's it going to start? Who's going to measure? Who's going to do the script? Who's going to analyze how well it's been done? If you don't give tasks to people, then it's not going to work. And you've got to work out things which are tasks, things that have to be done in order to get it done, and things which are tests, seeing if the task works, and then making a change. There's a difference between the two. You have to decide what your measures are, and I'll talk about these later in the measurement section. But really, these are the measures that are going to talk about how your process is working and the outcomes you achieve. So these are the two types of measures that you're really going to look at. And finally, you have to test your changes. Your first big test will be your first huddle. How did it work? Then you're going to analyze it and make a change to get it done better the second time. And you can do multiple tests of change. And these are measured every time, small tests, measuring, changing, till you get to the outcome that you want because your process is working. And finally, although it goes through all of this, it's measuring and working out how you're going to sustain it. And if you're in another hospital with more than one ward, how you're going to spread it to the next ward. Or originally, it's going to spread it amongst your own team. But that is something that you're going to look at. So these steps are quality improvements in a nutshell. And I'm going to take you through each of them so that you can understand how you're going to apply quality improvement methodology and theory to your project. So let's start with understanding your system. And this comes from microsystem theory. And it's really looking at a simple thing. How do we work? How do we do things here? You know, we are so busy that we just do it without understanding why and how we do it. And if you stand back and look at it, it's often chaotic. Why do we start our ward rounds in a certain way? Why do we do things? What happens when we work, and how do we work is a key question. What happens when we try to get change? So if you look at here, when we try to get change, sometimes you'll know exactly who's going to resist change because it's far easier doing it the same way over and over. An outsider may come in, and usually you could ask medical students who are rotating through different wards, what do they think of the way we're doing things? How does it differ from other places? Because often we are blind to it. And when we get change, you know often people say, we tried it, never worked here. Well, you're going to hear a lot about huddles, that we've tried it, never worked here. And you've got to say, well, how did you try it? Why didn't it work here? Did you use quality improvement principles? Were you doing it the right way in the first place? And that's what you have to really understand about your clinical microsystem. And over here is how do we work as a team? I mean, do we have a team? Have we ever had team training? Do we get together and work as a team? Because the huddle is about improving teamwork. In fact, most of our research was not based on improving deterioration, which is a long-term aim, but really on improving the way teams work. And you'll already see that in some of the videos later about teams talking about how they improved on their quality improvement journey, not just only getting outcomes for patients, but getting outcomes for teams. And this is really what I study in the microsystem. This is an interesting one. How do we tackle the big things? And that is usually resistance. That's how when things go wrong. What happens to the team? Do we come together? Do we discuss things? How do we deal with difficult colleagues? That's a very hard question to follow, but you have to ask about it because I can assure you, you will have resistance to the introduction of huddles, and you have to start thinking how you're going to deal with it. And how do you work with other teams is very important. We often find that that is a difficulty in healthcare. How do we work with the ED, for example, the emergency room? How do we work with general practitioners? Those are different teams. because it's very important for safety that we have good teamwork between the different microsystems as well as within our own. And if we improve in our own microsystem, how are we going to help others improve too? And what do we have to do when we finish this project? What do we else have to work on? Because you see, when you start improvement, you suddenly see other things that you can start improving. Because one of the questions will be, what kind of harm do we have? And usually the harms are in medication safety. One of our huddles was quite interesting, and that was at Watford. What they did is they introduced the druggle, which became very popular, which was a huddle just particularly looking at medication safety because they had a problem in medication safety. So they did a totally different kind of huddle, not one we asked them to do, and that became very popular, and the druggle is now being spread around the country just out of a question in one place that they had was slightly different to others. But actually, medication harm is the biggest harm that is occurring to children, so everyone should be doing something like the druggle. Now, the 5 Ps comes from the microsystem theories of Dartmouth, and you can always find this on their website. But I'm going to try and make it simple for you. What are the 5 Ps? The first is the purpose, our aim, our mission, something we never talk about. I think that our purpose shouldn't be exactly what is written on the bottle, which is we care for children, we treat them, we diagnose, and so on, but rather we keep the children in our care safe while we treat and diagnose problems. And safety should be our business. And that is very important. What is our purpose? Because unless you talk about safety being our purpose, then it will not be something that you do as part of your job every day, thinking of how do we keep our children safe. And one of the things to keep them safe, which is the huddle's about, is preventing deterioration that shouldn't have happened. So unless you make safety your purpose, it's not going to really happen. So what is our purpose? It also is quite important to go to the next one. Who are our patients? Because part of the huddle may be looking at those patients that we don't normally treat. They have different conditions. Now this really happens in a hospital where children are placed in the wrong bed because there are no beds on the ward they should be. And that's usually the children's hospitals. In the district general hospital, it might be a patient you don't normally treat that's now in your hospital and is now at higher risk. So who are patients, which are the reason we do our work, why we do our work, do we understand it? And of course the next P will be who the people, who the staff. And this goes back right to the early part of this talk where I talked about building into a team, looking at your resources. Do we know all about our staff, what their strengths and their weaknesses are, what their interests are? Because when we do the human factors part later on, you'll find understanding your staff is very important. And looking at patient safety, staff work and teamwork is essential in order to be safe. And dysfunctional teams that do not know about each other will not be safe. That's why the break in bed and spending a community spirit is so important, because there you learn about staff strengths and weaknesses, and it's essential for you to do that. Now we get back to the processes. And if you think about it, this links back to Deming again. Understanding the processes, how things happen, how they work, and understanding the variation of the processes. And of course, people make up the processes. Here you get the lenses of profound knowledge that he called in, right built into the 5 Ps. And finally is the measurement, the patterns, how we do things. Do we measure what we do and study the variations so we can continue to improve? So these are the 5 Ps. I'll go through each of them. The purpose, do we have a clear understanding of what we do? If not, it's about time to do it. Now I'm going to apply this for the huddle. When you implement the huddle, what is the purpose of the huddle? Often, people think the purpose is to regurgitate what happens on the ward round. It's not a handover. The purpose of the huddle may be, as they did in the druggle, to talk about medication harm, or it may be just to talk about which children are we worried about, that we have to be careful about deterioration. So defining the purpose of your huddle is essential. How your system works to enable the huddle to happen is important. When will it happen? And how can you identify what should happen in the huddle so that it can happen with good planning and not add additional work to people? So how can it be part of what they do so it's not something in addition to what they do? Because your first pushback is going to be, we don't have time. We don't have the 10 minutes in the day. And I can assure you, no matter how busy your staff are, there's a lot of wastage on time when they're doing things that they shouldn't be doing because they haven't had a chance to plan and manage going forward. The next one is studying our patients. What do we really know about our patients? And really, this is what the huddle is about. It's about knowing which patients may deteriorate before they deteriorate so we can mitigate. So really studying the patients. And in order to do that, you have to understand the characteristics of your patients. In a general hospital with a general pediatric ward, your patients are very different from a children's hospital, which are in subspecialty wards, in which the patients will be different from ward. And therefore, your huddle will be different from ward to ward because the characteristics of the patients are different. And very important, what do they think about us? Do they think we are safe? It's very important to understand the viewpoint of the customer, in this case, parents and patients. The next point is looking at the people who make up the microsystem. Because when you have your huddle, you have to understand which are the people that should come to the huddle. You should look at what their concerns are, what their ideas are, before you start it. I can assure you that the first thing will be is about time. You'll get people saying we don't have enough time, we can't find 10 minutes in the day to do the huddle. But there is always that time available because there are lots of things that shouldn't be being done, and often they're done because you're not anticipating what's going to happen. So really try to find the concerns of people before they push back. Another area we'll say, well, we discuss patients on handover, we discuss patients on the ward, but the purpose of handover and wards are very different. The handover is handover information from one clinical team to another in the microsystem at a point of time when the different staff are going to be on duty. A ward round is discussing everything about the patients. The huddle purpose is totally different. In our case, the huddle is to look at the patients who may deteriorate and anticipate it ahead of time so that we can mitigate against it. So understanding what the purpose is very important for the staff, but you have to understand that the staff will have different comprehensions of what you're doing. So you have to have clarity here. You also have to understand the skill mix of your staff. Maybe there's someone who could lead the huddle because they're good at doing that. Maybe someone who's not the clinical lead can take different parts of the huddle responsibility. So understanding your staff is very important. These can apply to any part of the work that you do. You then look at your system and how do we work, when we do ward rounds, when do we find out about staff, what is the best time of the day to do things, what's our routine, how does it differ when different people are on. Is it different on a Monday from a Friday? Because I know definitely Friday and Saturday is different from the weekdays. It differs at night. So studying this is very important, and that's the study of your system. And are these sensible? And often they're just not sensible at all. They're there because they've always been done that way and no one's ever challenged it. So now if you look at this is a process map. Now actually this comes from a very good guide called the Oram Guide. It was from South Africa. So it's about here at a maternity hospital. A woman arrives at reception and here registration, examined, fully dilated, labor ward, monitored, normal process. There we go, normal process, not normal process by doctor. Normal process is going to go to delivery and home. So you can see a process with all the steps in the process. And the triangles are decisions, where decision is being made. That's just the way you do process maps. Now the easiest way for the process to be done is to follow the patient. What happens to a patient on the process? Or if you want to understand how do we discuss patients, follow a ward round. And at the ward round, you'll have a good time of looking at it. So process mapping is very important. And we're going to ask you to study how does your process of the huddle happen? How does it start? How is it run? How is it finished? How is it analyzed? And how are decisions put into action? So that's your process that you're going to look at. And if you really want to study more, we can provide more information on how to do a process map. One of the things in the process map, and I put this here so you can read it, is the 5 whys technique. The 5 whys technique comes from lean methodology. And what you really do here is ask 5 questions. Why does the ward round always start late? As you know, most ward rounds don't start exactly on time. Why do they start late? And then you can say, well, because the doctor's not there. Why is the doctor not there? Because the ward round always starts late. Okay? Which doctor's not there? And you carry on, you ask 5 questions, and finally you find out the reason why it started late. And this it's a very simple technique. And I've put the full text here, about here. And for example, why do we have no employment in the community? There are no jobs. Why are there no jobs? Because investors are nervous about creating a new business. Why are investors nervous? Because of crime. Why are they worried of crime? Because the newspapers always talk about crime. Why do they talk about crime? Because they don't have access to finding out what the community is doing about crime, etc. So you go down and down the things so you can get to the 5 whys. It's a very good way of doing it. And when you're doing your huddle, so this is a technique you can use to see how your huddle is working at any one time. The fishbone, which is the Ishikawa diagram, also from lean methodology, is a very good way of analyzing it. Now, in quality improvement and patient safety, we use this 2 ways. One, to analyze our problems and where we want to improve, and a second way on how to analyze root cause analyses when things go wrong, adverse events. And usually over here, you'd have the 5 or 6 areas of human factors: the environment, the culture and teamwork, the people, the patients, the tools and tasks they've asked to be done. And each of them, you then have your 5 whys, which are the causes that may be. So that's a diagnosis of the problems. Now in this talk, I really don't have time to teach you in detail each of these. So I can leave it to guides like the ORAM guide, which gives more detail on how to do this. But what we want you to do is analyze your problems that you may have in your system by studying the process, applying the 5 whys, and then also diagnosing the problems using the Ishikawa diagram. And as you can see, there's your problem of aim. So what we'll do here, for example, you can put children deteriorating over there. Why do children deteriorate? So I'll just use one of these. We look at people, and the people here will be the staff. And you can put here the nurses. What's their training like? Can they detect things? Are they recording things correctly? Are they doing the vital signs correctly? The doctors. Are the doctors well trained? Do they know how to intervene? Do they work as a team? Can you see I can move them down for each of these just on the people? And likewise for each of those. And that's what you could do in order to find out why children deteriorate on your ward. And that helps you get to your intervention. The patterns are your measurements. And we're going to ask you to measure a number of things appropriate for your ward, appropriate for where you are. So what you'll measure in a children's hospital will be very different from a general ward in a district general hospital. You'll measure different things because your outcomes and your processes are different. But what we'll want you to do is measure how you do your huddles. And that process is very important. And you've got to look at what information you have available. And you'll be surprised how much you do have. You don't want measurements to become difficult. It must be part of what you do. And what we're going to try to do in the huddle is allow you to measure your quality and safety in real time so it doesn't become a burden. And we use different things to do that in order to display our data. Finally, you have to really look at your aims. And this is a methodology that comes from IAP in the USA and been spread around the world. The quality improvement model called Model for Improvement, where you have an aim asking a question, what we're trying to accomplish, and there's a SMART aim, specific, measurable, actionable, relevant, and a time frame by when you're going to do it. You're then going to have How we know change is a difference, and that's your measurement. Do we have before data, after data? In our case, it'll be number of days of unplanned transfer to higher level of care. So if you're in District General Hospital, you want to get that number up and up and up, so that hardly ever happens. And so that's a measurement. So you start measuring beforehand. And then what changes is going to be your changes you're going to test. How we do the huddle, you're going to plan it, you're going to do it, you're going to study how it happens, and then you're going to act. Now, as a pediatrician, I used to see children with epilepsy, and this is exactly what I did. Here they'd come. What we try to accomplish, we try to decrease the number of seizures. How we know change the difference? We're going to ask the mother to measure the number of seizures. What change are we going to do? We're going to start with a medication, let's say sodium valproate or carbamazepine. Plan. We're going to give carbamazepine. Do. The mother's going to do it, and the mother's going to measure. Study. At the next appointment, we're going to see if it worked. Were there side effects? Did the child take the medication? Did the seizures go down? Act. We're either going to stay on the medication at the same dose, or we're going to improve it, increase it, and then we're going to start the cycle again. This is called PDSA. It was from a guy named Shewhart, who was another statistician who taught Deming as well. And this idea of plan, do, study, act is something we do all the time, every day, without knowing that we're doing it. In the huddle, how it will work, we're going to plan a huddle, we're going to do it, we're going to study what happened, we're going to make some changes, we're going to plan the huddle, do the next one, study what happened, make some changes, until we get where we want to go. And that is the theory that we're going to use. That's the method that we're going to use based on the theories of Deming on how to improve. Now, we all have a theory of change. Now, theories of change are often hunches. We're not quite sure how to do it. So these guys, and this is Lloyd Provost and Brandon Bennett, came up with a great book that you can download from the internet. You just put that in, and it shows you how you can have a conceptual idea about the theory of change. Over here, the aim or outcome, which in our case would be decreased deterioration. At Watford, it was to decrease medication harm. So that's where they had the druggle. You're going to have the primary drivers, which are the key things you have to have in order to get improvements. In order for these primary drivers to happen, you're going to have some secondary drivers, things that may have to have the primary drivers to work. The team will have lots of ideas, and then you're going to have change concepts that you're going to do PDSA on, you're going to test. So how does this work? There you see it, the aim, the primary drivers, there you got it, and there's the model for improvement, where you're doing the testing. All these testing over there, any ideas, relates to achieving this aim. This is your theory of change. It's very important that you do this at the start, and I'm going to give you one for quality for this program. Here's a completed one from the book, which is really about high-risk adults and surgery, could be children, with medication management at discharge and post-discharge. And it tells you can study this separately on how to look at it. But this is a completed driver diagram with some change concepts over here, derived from the change ideas. And these are the things that they're going to test in order to achieve these secondary drivers or high-risk drivers. So let's see how it looks for us on huddles. So first thing is this idea. We want to increase the number of days between unexpected transfer to high-level care from what it is in our baseline to where we want to go. Okay, let's say 100. It's every 20 days. We want to go to over 100 days. Okay, that's what we want to do. Here are some primary drivers. Now, the thing about context is that in your context, these may be different. Clinical leadership, very important. Communication, how we communicate. Do we have an early warning system that we use? Do we have huddles? And do we have a good training program? And there I've put some secondary drivers pulled in here. So here I'm building a theory of change that may be different in your setting because your team will help you design the theory of change. But we know to do all of this must happen. And for these things to happen, for explained leadership, if we don't have the doctors on board, if we don't have the nurses, if we don't have people involved, like in communication, if we don't use different kinds of communication, then things aren't going to work. This means, in order to know that, we have to measure each step. And the measures we're going to have are process measures, what is needed to achieve the outcome. And this, for our case, is how do we do the huddle? Did everyone speak? Did everyone feel that they had a chance to express their views? Did we identify the right children? The outcome measures is what happens to patients, which is, in our case, is decrease in deterioration. What happens to staff as well? An outcome measure might be. Balancing measures might be positive or negative things. Because we do in the huddle, we stop doing other things that are important. So we have to have these three kinds of measures, and later on we'll be talking about measures for this program. And these may be positive or negative. We always think about negative things, but we also think about the positive that we didn't anticipate was going to happen. Often it might be, for example, we try to decrease deterioration, and what we find out, we decrease length of stay because we're talking about the patients more often, and we're identifying blocks as well. The next area is underlying the whole program. You saw that clinical leadership was at the top of my driver diagram, of my theory of change. I really believe that you won't make this successful unless you have clinical leadership. And I'm not talking only about doctors. I'm talking about nurses, allied professionals, pharmacists, physios, OTs, anyone who cares for the patient. So for that leadership, of clinical leadership, we have to think about it very specially and make sure that everyone's a leader. And that means we have to distribute leadership. You have to have a vision. Is it possible to have a long period of time that you do not have deterioration, to anticipate when things go wrong? You have to give people hope that they can get there. They can really make a difference, because people will not work with you unless there's hope that things will get better. And that shows a lot of courage. And courage is something that we often don't have. Courage to make change, courage to challenge, and courage to take on difficult tasks. I started this talk talking about respect. You have to respect where people are, even when they don't want to change. Try and understand why they don't want to change, because that's the way you'll get them to change. And you have to develop the skills, the quality improvements in patient safety, knowledge, and basis in order to underpin what you want to change. Finally, you have to give time and space. Now, time and space is often the reason people do not change, because they say we do not have time. But when you study the process, you will find where the time can be made in order for things to improve. Local capacity is really based on your teamwork. What we want to do is really change things. And I'm going to just show you one slide, I think, here on how we want to go forward. And this comes from a fantastic paper by Bill Lucas, which you can download from the Health Foundation's website. And this is called Habits of the Improver. The idea is that we want patient safety to be a habit. It's what you do every day. You do it because it's a habit. And habits are positive or negative. You want this to be a positive habit. And you will see over here that in these habits, there are many of the things we've been speaking about in the last 40 minutes or so. Who are the influencing people? How do we learn? How do we work as a team? How do we tolerate uncertainty? What risk do we talk about risks? Do we have team play? How do we generate ideas? Do we think in systems or only individuals? How do you co-produce with other people? The habits of the improver are aimed at building sustainability. What you want to do is make the huddle the way you do business. It happens because it happens. People do it because it becomes their habit. They talk about safety and quality because it's their habit, because that's the way they do things, not because someone tells them we want you to be safe. That's how we're starting. We say we want you to be safer. We want to move to a position where this is the habit, the way you do things. The last point is about learning and sharing. You have to share the learning. That's very important. And that's sharing amongst yourselves and sharing amongst other teams. And this is what we are doing here at the college. There are social movements for safety, and these social movements are all linked together. We have it Making It Safer Together, the MIS group, which is a voluntary group from around the country, people joining up in order to share good quality and practice. There's a Meds IQ, which is focused really on medication safety. And finally, there's the SAFE program, which we're talking about today. Internationally, there's a Pediatric International Patient Safety and Quality Community, PIPSQI, which you could join, which you could look at their website, and we share information from there. And possibly the biggest movement on this is the Solutions for Patient Safety. And these are some of the measures that they have on their website. These are over 100 hospitals in the USA who have said, safety is our business. We want to share what we can do. So what we really want you to do here is share your successes and your challenges with us. From that, we will learn together. You can do that on WhatsApp, on Facebook, in our learning sets, or you can just send us your successes so we can put them on the website. Thanks very much.